maybe chemoradiation therapy was considered as again preferred, and the standard should remain standard. And so there's no difference in terms of long-term toxicity by doing locally chemoradiation therapy. So now this is the current study. Look at the difference. Try to look at, can we use the immunotherapy to further improve the outcome. So basically at this point, so there are low and intermediate and high risk. So we know for low risk, it's very safe to do de-escalation. For moderate risk, we don't know how to do it. For high risk patients, actually we have to escalate. So I want to just point out there's one study, two studies looking at escalation treatment with a surgery followed by chemoradiation therapy, the high dose, low dose, high dose radiation, basically intensified treatment. There's another study to intensify treatment looking at the surgery followed by a radiation, low dose, intermediate dose, and with immunotherapy. Because the main metastasis, distant metastasis remains the main risk of recurrence. So that's why nowadays we have this study trying to introduce induction immunotherapy followed by surgery and followed by chemoradiation therapy with immunotherapy. So really escalation. So in summary, we know HPV-mediated oropharyngeal cancer is a really different entity now, has better prognosis, and the incidence is rising. So it is sensitive to treatment. It's really important to be able to figure out how we can do less to have less complications, have better quality of life. So many studies are still, clinical trials still ongoing, and the results are waited. Thank you.
Thank you, Dr. Zen. Our next speaker is Dr. Apar Ganti. He's a professor in our medical oncology division at Nebraska Medicine, UNMC. He will be presenting on systemic therapy for squamous cell carcinoma of the head and neck. Thank you, Apar.
Thank you, Dr. Wall, for the introduction, and I'd like to thank the organizers for inviting me to speak. As Dr. Zen said, despite the best efforts to exclude medical oncologists from the treatment of head and neck cancer, there's not been much success, and there is a significant role that we as medical oncologists play in the management of patients with this disease. These are my disclosures. So I'll be talking about the role of chemotherapy in different aspects of head and neck cancer, briefly talk about definitive chemoradiation in oropharyngeal cancer, role of induction chemotherapy in nasopharyngeal cancer, and talk about adjuvant chemoradiation, and spend the last few minutes talking about metastatic disease where there's been a significant advances in the last few years. So head and neck cancer as a whole is the fifth most common cancer worldwide, although as Dr. Syed said, it's not such a big problem in the United States. It is the most common neoplasm in Central Asia. The male to female preponderance of anywhere between 2:1 to 4:1. And there are geographical variations in the site of the head and neck cancer. For example, in the Indian subcontinent, oral cavity and oral tongue cancers are very prominent, probably due to the tendency there to chew betel leaf. Nasopharyngeal cancer is very common in Southeast Asia, especially Hong Kong. And then in the other populations, especially in the US, it's more oropharyngeal. Until a few years ago, laryngeal cancer was very common in the Western Hemisphere, presumably because of the smoking habit. So when do we use definitive chemoradiation? The major indications are patients with locally advanced or locoregionally advanced head and neck cancer, certain base of tongue lesions that may be technically resectable, but surgery can cause a functional glossectomy, large oral cavity lesions that require composite resections, which might result in cosmetic defects, patients who have major medical comorbid conditions that preclude surgery as a treatment option, and also organ-sparing approach in cases of resectable cancers of the larynx, oropharynx, and hypopharynx. These data are old, but still relevant today. This study was RTOG 9111, designed in the early 90s, where patients with stage 3 and stage 4 squamous cell cancer of the larynx, either glottic or supraglottic larynx, were randomized to 3 arms: concurrent chemoradiation with cisplatin at 100 milligrams per meter squared given once every 3 weeks, Then there was an arm that got induction cisplatin and 5-FU for 2 cycles. And following that, if the patient had a complete or a partial response, they got a 3rd dose of chemotherapy followed by radiation. If they got anything less than a partial response, then they went straight to surgery. And then the 3rd arm received radiation alone, which was the standard of care back then. These results were published about 12 years later. And what they found was the laryngectomy-free survival was similar in the chemotherapy arms, both the concomitant chemoradiation and the induction chemotherapy, but better than radiation alone. The local regional control was better in the concurrent chemoradiation arm, followed by the induction chemotherapy, and radiation arm did the worst. But in terms of overall survival, there was no difference in the 3 arms, with 5-year overall survival of around 59% in the induction chemotherapy arm, 55% in the chemoradiation arm, and 50% in the radiation alone arm. So these are the survival curves here. You can see that for laryngeal preservation, concurrent chemoradiation was better than the other 2. Same thing with locoregional control. But as I said, there was no difference in overall survival. And based on this, radiation with concurrent high-dose cisplatin became the standard of care, and till date is still the standard of care for patients with locally advanced head and neck cancer. Moving on to adjuvant chemoradiation, this is chemoradiation after surgery. The rationale for this is that locoregional recurrence is the most common site of failure following surgery and radiation. And so the thought was, if we could add something to radiation, we potentially could potentiate the effects of radiation and improve local control. And so 2 trials were designed, one in Europe and one here in the US. This was the EORTC 22931 trial that looked at adjuvant cisplatin with radiation versus radiation alone in patients who had locally advanced cancers or cancers that had a positive margin despite resection, and also patients who had extranodal extension on the resection specimen. And what the study found was that combination of chemotherapy and radiation was better in terms of progression-free survival, overall survival, and also decreased the risk of local or regional relapse when compared to radiation alone. And the RTOG 9501, which was a similarly designed trial with a few minor differences in inclusion criteria, showed basically the same thing. There was better disease-free survival, better overall survival, and better local and regional control with chemoradiation compared to chemotherapy. So then this started a big debate into which patients actually needed adjuvant chemotherapy in conjunction with radiation. And this was an analysis of the 2 trials combined. And you can see here, this is a busy slide, but basically the blue bars are patients who got radiation alone for oropharyngeal cancer. The red or maroon bars are patients who got chemoradiation for oropharyngeal cancer. The green bars are all other head and neck cancers who got radiation alone. And the purple bars are the ones that got chemoradiation for all non-oropharyngeal cancers. And as you can see here, these are patients who had either positive margins or extracapsular extension. And you see across the board, as both in terms of local regional control, disease-free survival, and overall survival, addition of chemotherapy, as you can see in the brown and the purple bars, are better than no chemotherapy for the group of patients that had extracapsular extension or positive margins. And so today in our clinical practice, what we tend to do is anyone who has a positive margin that cannot be re-resected, or patients who have extracapsular extension of the tumor are offered adjuvant chemotherapy. There's been a long debate between what chemotherapy to use. As Dr. Zen said, cisplatin high dose is not liked by too many people. And so there's always been a lot of debate about which patients should get high dose cisplatin, which patients could get something else. And so there was a trial that was just presented at ASCO this year. Published in, this is studies out of Japan, JCOG 1008. This trial was a multi-institutional trial that looked at postoperative high-risk squamous cell carcinoma of the head and neck, pathologic stage 3 or 4, with microscopically positive margin and or extracapsular extension. And the primary site could be oropharynx, larynx, oral cavity, or hypopharynx. They were randomized 1:1 into either every 3 weeks cisplatin with radiation, standard dose 100 milligrams per meter squared. Postoperative radiation was 66 centigrade in 33 fractions, versus weekly cisplatin at 40 milligrams per meter squared, again with the same radiation. And what they found, that the weekly arm had a better overall survival, almost a 12% improvement in overall survival, which translated to a 31% reduction in the risk of death with a p-value that was highly statistically significant. Based on this, the Data Safety Monitoring Committee recommended that this trial be closed. And while we wait for the final results to be published, if these results hold true, then this will soon become the standard of care for patients with postoperative need for chemoradiation. Moving on to nasopharyngeal carcinoma, for long, concurrent chemoradiation has been the standard of care for EBV positive nasopharyngeal carcinoma. Till this study was published recently out of Hong Kong. This was a parallel group, multi-center randomized phase 3 trial that looked at gemcitabine and cisplatin induction chemotherapy followed by concurrent chemoradiation versus concurrent chemoradiation alone. And this included all patients with locoregionally advanced non-keratinizing nasopharyngeal carcinoma. And what they found was that induction chemotherapy was better than standard chemotherapy, both in terms of recurrent-free survival and overall survival. One of the problems that I have with this particular study is that it did not allow adjuvant chemotherapy for those patients who received chemoradiation upfront. And while there is a lot of debate about the role of adjuvant chemotherapy, it is still considered standard of, or was still considered standard of care in those patients who were able to tolerate that. And so with that caveat, induction chemotherapy is still, I think, is an important tool in the management of nasopharyngeal carcinoma, especially those that are HPV or EBV positive, sorry. So moving on to where chemotherapy or systemic therapy has the major role to play in this disease, it's in the setting of metastatic head and neck cancer, where patients are no longer candidates for either surgery or radiation. Multiple different agents have been shown to be effective. Response rates typically are in the 30% range, and median overall survival with any single agent is about 6 to 7 months. The EXTREME trial that was published almost 12 years ago looked at a combination of cisplatin and 5-FU and with or without cetuximab. And what they found that the addition of cetuximab improved overall survival by about 10 months. But the addition of cetuximab was associated with a significant increase in the side effect profile. And in the setting of metastatic disease, where you're more interested in palliative treatment, adding side effects did not make a whole lot of sense. So even though it improved overall survival by about 3 months, it did not really take off very much because patients were too sick to get the triplet regimen. In this setting, there's been a lot of hype about immunotherapy. Immunotherapy drugs have been used successfully in multiple different cancers, and head and neck cancer seem to be a prime target because of the nature of the disease and because of its etiology. So briefly, for those of you who are not familiar, this is how immunotherapy works. So when cancer cells die, they release antigens. These antigens are then presented to the dendritic cells or the antigen presenting cells. These are primed, and these antigen presenting cells then activate the cytotoxic T cells. The cytotoxic T cells then are trafficked to the tumors, and then they infiltrate into the tumors, recognize the cancer cells, and kill them. And this cycle goes on again. What immunotherapy does is, in our immune system, there are a number of natural checkpoints which prevent the immune system from becoming overactive. And unfortunately, in the setting of cancer, these checkpoints are activated. Example, the tumor cells have this protein PD-L1, which binds to a corresponding protein called PD-1 on the tumor-specific T cell. And when these two bind, the tumor cells become anergic or stop responding. Similarly, there's another antibody called CTLA-4, which is also a checkpoint. And so when that is activated, there is tumor T cell energy, and the cancer is not recognized as being foreign. What immune checkpoint inhibitors do is that they break this bond between PD-1 and PD-L1. You have PD-1 inhibitors and PD-L1 inhibitors, both of which functionally work in the same way for all practical purposes by breaking this bond and allowing the tumor cells to be released of the energy and therefore can attack the cancer cells. Keynote 40, a trial that we were part of, compared pembrolizumab with a standard of care chemotherapy in patients who had failed first-line chemotherapy for metastatic head and neck cancer. And what we found was that the overall survival was better with pembrolizumab, with a 20% decrease in the risk of mortality and a p-value of 0.01. So since it was effective in the second-line setting, the next natural step was to see if it would be beneficial in the first-line setting. Interestingly, what was found was that the PD-1 expression, PD-L1 expression on the tumor cells and the immune cells seemed to predict for the degree of response to these drugs. So in this here, the first panel shows pembrolizumab versus chemotherapy standard of care in any person whose tumor had a combined positive score of greater than 1, meaning at least 1% of the cells in the tumor, both immune cells and cancer cells, had to have PD-L1 expression. Whereas if the expression was more than 50% in the tumor cells, the tumor proportion score of greater than 50%, the magnitude of benefit was that much higher. Which brings us to this study, Keynote 48, a complicated study design. This looked at all patients who had unresectable head and neck cancer, and they were randomized to either pembrolizumab monotherapy, pembrolizumab plus chemotherapy, or the extreme regimen that I had described earlier of carboplatin or cisplatin, 5-FU, and cetuximab followed by cetuximab. The pembrolizumab monotherapy arm got pembrolizumab for 35 cycles, which is about 2 years. The pembro plus chemo arm got 6 cycles of chemo plus pembro, followed by maintenance pembro for up to 2 years total. And they were randomized to 1:1:1. Treatments were stratified, patients were stratified based on tumor expression of PD-L1 greater than 50% versus less than 50%, P16 status, positive versus negative, and ECOG performance status 0 or 1. This was just published last year, and as you can see on the panel on the left, this looks at pembrolizumab with chemotherapy comparing with cetuximab with chemotherapy. And at about 2 years, there was about a 10% improvement in overall survival, which almost a third of patients being alive at 2 years. Here, this panel here shows the comparison between pembrolizumab alone versus cetuximab plus chemotherapy. Again, at 2-year survival is about 27% compared to 19% in the chemo versus cetuximab arm. So based on this, the US FDA just approved the use of pembrolizumab either as a single agent or in combination with chemotherapy as the first-line treatment for any patient with metastatic head and neck cancer with a PD-L1 combined proportion score of 1% or greater. So in conclusion, definitive chemoradiation plays a role in the treatment of patients with locally advanced oropharyngeal cancer, laryngeal cancer. It is an important organ-sparing approach. Adjuvant chemotherapy with radiation is recommended for patients who have positive margins or extracapsular extension after surgery. And weekly cisplatin may become the standard of care for these patients. Induction gemcitabine plus cisplatin followed by radiation is a treatment option for EBV positive nasopharyngeal cancer. And immunotherapy, especially pembrolizumab, is the mainstay of treatment for patients with metastatic head and neck cancer. Thank you.